this section, we are going to be having a discussion of vasculitis. When we talk about the term vasculitis, it simply means inflammation of the blood vessels. When we talk about the inflammation of the blood vessels in this condition, this is usually going to be an example of a non-infectious condition. And this kind of vasculitis is usually going to be an example of a immunologically mediated process. Now, why do we need to be having an idea about this kind of a vasculitis? Whenever we have any kind of an inflammation which is going to be responsible for causing an involvement of the blood vessels, it can be responsible for causing a reduction in the lumen. The decrease in the lumen can be because of the presence of a thrombus formation, or this can be because of the presence of fibrosis. As a result of this particular fact, any organ in which we are going to be having a vasculitis is going to be having a development of ischemic symptoms. So patients are going to be having the development of ischemic symptoms at the time of vasculitis. When we talk about the classification of vasculitic disorders, we can divide them into multiple subtypes. The commonest classification that we follow happens to be dependent upon the size of the vessel that is going to be affected. So when we have an example of a vasculitis which is going to be characterized by involvement of the big blood vessels, this condition is given the name of large vessel vasculitis. By definition, we should be having an idea. The meaning of the term involvement of large vessel simply stands for the involvement of aorta or its major branches. Now, when we talk about large vessel vasculitis, we have got two important examples of the disorders in this category. The first important disorder about which we need to have an idea is a condition that is given the name of temporal arteritis. Why exactly should a physician be familiar with the disease like temporal arteritis lies in the fact that this is the most common vasculitis that we have in case of adults. Classically, this is an example of a disorder which is going to be affecting a female patient, and that is going to be affecting the person in the age group of more than 50 years. So it's the commonest vasculitis that we see in the patients. Now, what we have as an important finding in this kind of a disease happens to be a fact that these patients are going to be getting the involvement of the aorta, and what we get in these patients is involvement of the carotid artery. So as most of us do have an idea about the fact that when we talk about the carotid artery, patients are going to be having the involvement of the external carotid artery, and patients are going to be having an involvement of the internal carotid artery in this condition. One of the terminal branches of the external carotid artery about which we are familiar with from a knowledge of anatomy happens to be the superficial temporal artery. And this is an example of a vessel that is very characteristically affected in a patient suffering from temporal arteritis. So the disease derives its name because of the inflammatory condition affecting the temporal artery. Now, what exactly is going to be the manifestation that we see in this kind of a disease? If you look at the clinical picture of a patient suffering from this kind of a trouble, the patients are going to be having the development of a headache. This kind of a headache is going to be an example of a localized headache. So patients have the inflammation of the superficial temporal artery, and this superficial temporal artery is present along the lateral margins of the forehead. That's exactly where the patients are going to be having the development of a headache. At the same time, the patients may also be having the development of a complaint, which is the presence of jaw claudication. Involvement of the carotid artery is associated with involvement of the mesenteric artery as well. So what we find in these patients is whenever the patient is engaging in chewing his food, the muscles of mastication are not going to be getting the desired or sufficient volume of blood. As a result, when there is going to be an ischemic pain at the time of muscle activity, it is given the name of claudication. So patients are going to be having a development of jaw claudication. Why should we be familiar with this kind of a fact is what is asked as a Heil stuff on the exams. the headache is happening to be the most common symptom that we see in a patient suffering from temporal arteritis. On the other hand, when we talk about jaw claudication, this happens to be the most specific symptom that we see in a patient suffering from temporal arteritis. Apart from that, this being an example of an inflammatory condition, patients are going to be having the development of fever, they are going to be having the development of malaise, and a lot of times patients are going to be having the presence of complaint like joint pain and the presence of muscle pain. So when the patients are going to be having the presence of joint pain and the patients are having muscle pain, this is an example of a condition which is being referred by the name of polymyalgia rheumatica. Characteristically, what is seen in these patients would be that the patients are going to be having predominant involvement of the shoulder girdle, and that can also be associated with the involvement of the pelvic girdle. So presence of muscle pain, presence of joint pain is what is being given the name of polymyalgia rheumatica. So that is an example of a non-specific manifestation that may be seen in these patients. Now, any patient who is going to be having this kind of a trouble, how exactly would we investigate this patient and what exactly do we expect to find? When we make a diagnosis of these patients, we start with the routine investigations. This is an example of an inflammatory condition, so patients are going to be having the higher value of total leukocyte count. This is an example of a condition in which the patients are going to be having a higher value of ESR as well. Classically, the value of ESR in these patients is going to be extremely high. It may be even exceeding more than 50 millimeters in the very first hour itself. So the presence of a high ESR is suggestive of the fact that the patients are going to be having the presence of an inflammatory condition. However, what we must always remember for these patients happens to be that the investigation of choice for confirmation of diagnosis of this kind of a condition happens to be biopsy. Now, there are certain important facts that we need to be familiar with so far as the concept of biopsy in these patients is concerned. Let us just try to have a look at the vessel. Say for example, if this is the vessel affected in the patients, what we have in these patients is there is an involvement of the blood vessel in a patchy fashion. So the lines that I am trying to draw over here happens to be the patchy involvement of the blood vessels. Why is that important for us to remember is because of the simple fact, whenever we wish to take a biopsy, possibility is that you have taken a biopsy from an unaffected area, or the possibility is you have taken a biopsy from an affected area. But what we do for avoiding this kind of a trouble, to have a chance of the tissue from the affected area and a chance of a tissue coming from an unaffected area, we need to remember the fact that at least 1 centimeter of the tissue has to be taken in context of the temporal artery biopsy. Now, what we find in case of the biopsy findings in these patients is going to be, this is an example of a condition which is going to be having the presence of granuloma formation. Recall what we had discussed earlier during our section of inflammation. Whenever you are going to be having the presence of a granuloma, this is quite commonly going to be having the presence of giant cells. And because we are having the presence of a granuloma in this condition, so temporal arteritis is the first example of a granulomatous vasculitis that we are discussing over here. Second fact, these patients are having the presence of giant cells in their biopsy. So this is an example of a condition which is also known by the second important name of giant cell arteritis. Temporal arteritis is having a second important name. It is also known by the name of giant cell arteritis. What we do need to remember regarding these patients would be a simple concept. In spite of our best efforts, there may be a probability that the piece of the arterial tissue that you have taken may be actually a normal tissue. So what that means is that if you are having the presence of a negative biopsy report, it cannot shortly rule out the presence of temporal arteritis. So we can just do our level best to have at least 1 centimeter of tissues. We can go in for something like multiple biopsies, but remember the concept, presence of a negative biopsy does not rule out the presence of temporal arteritis. Why exactly is the physician expected to be familiar with an example of this kind of a disease lies in the fact that the patients can be having an involvement of the internal carotid artery. If there is an involvement of the internal carotid artery, this can be associated with the involvement of the ophthalmic artery. And if there is going to be any involvement of the ophthalmic artery, this is going to be associated with a decrease in the blood going to the eyes. And when there is going to be a decrease in the blood flow to the eye, this can be responsible for causing sudden onset of blindness. So why exactly do we need to be familiar with this kind of a condition lies in two important facts. Fact number one, it is an example of the commonest vasculitis that we have in case of adults. Fact number two, this is an example of a condition in which the patients are going to be having sudden onset of blindness. So this is an example of a condition that may be encountered by you in your practice. For that very reason, if a patient is coming with this kind of a symptom, we should be having an idea exactly how to manage this kind of a patient. We must be familiar with the fact that the drug of choice for the management of this kind of a condition happens to be administration of steroids. So steroids happen to be the drug of choice for the management of this kind of a condition, and timely administration of steroids can actually be responsible for preserving the vision in these patients. There may be a possibility that you may not be having the presence of a nursing home or a hospital nearby, so steroids may be not available to you directly. What can be done as an intermediate arrangement is the patients can be asked to inhale and exhale in the same polythene bag. This is responsible for causing the inhalation of a greater amount of carbon dioxide. And when there is going to be an inhalation of greater amount of carbon dioxide, it is going to be acting like a vasodilator. So sudden onset of blindness, for some time you can be buying the time by inhalation of the higher concentration of carbon dioxide, and this is achieved with the help of inhaling and exhaling in the same polythene or plastic bag. So otherwise the drug of choice happens to be something like steroid administration. This is what we need to have an idea so far as the condition temporal arteritis is concerned. Talking about the second important example of a condition, the second important example of a large vessel vasculitis about which we need to have an idea is a condition that is given the name of Takayasu arteritis. Takayasu arteritis. Takayasu arteritis is an example of a large vessel vasculitis, but this is a condition that is seen in case of younger patients. So usual age of the patients is going to be less than 50 years of age. Now the name of the disease may be giving you a hint. This was an example of a disease that was first described in Japan. So that is an example of a disease that is going to be relatively more commonly seen in case of Asians. What we have as an important feature in case of this kind of a disease lies in the fact that this kind of a disease is going to be having an involvement of the aortic arch. So let me just make a crude representation for the understanding of the manifestations in case of this kind of a disease. I'm just making a representation of the aortic arch in a simplistic fashion. If this happens to be the aortic arch, what we are having on the right side is going to be the presence of the brachiocephalic vessel. This brachiocephalic vessel is going to be dividing into the right common carotid and the right subclavian vessel. On the left side, we do not have the presence of a brachiocephalic, so this is going to be the left-sided common carotid vessel, and this is going to be the left-sided subclavian vessel. Now, what we find in a patient suffering from Takayasu arteritis happens to be involvement of the aortic arch. So this is an example of a condition that is known by the second important name of aortic arch syndrome. Along with the fact that the patients are going to be having the involvement of the aortic arch, patients are going to be having a trouble or the involvement of the origin point of the vessels. If there is going to be an involvement of the origin point of these vessels, less volume of blood is going to be going inside these vessels. As we can understand, when we trace the subclavian vessels from the neck region, it is going to be continuing as the axillary artery. Axillary artery then continues as the brachial vessel. and the brachial artery then continues as the radial and ulnar artery. If there is an inflammation at the origin point of the subclavian vessel, this is going to be responsible for causing less blood going inside the axillary, less blood going inside the brachial, and less blood going inside the radial and the ulnar vessels. Because of this particular fact, what we find in these patients is that the patients are going to be having a feeble pulse, or the patients are going to be having a weak pulse. If the disease happens to be very severe, there is a possibility that the physician may not be able to palpate the pulse of the patient as well. So that is the reason why the disease is also known by the other important name of pulseless disease. So when we talk about this kind of a condition, Takayasu arthritis, it is characterized by two other names. It is going to be given the name of aortic arch syndrome. It is also known by the name of pulseless disease. We need to be familiar with the fact that this is a disease which is going to be affecting young adults. The second fact that we must always keep in mind regarding this kind of a condition happens to be in context of its microscopic appearance. At a histological level, this is again an example of a large vessel vasculitis which is going to be associated with the presence of a granuloma. So this is the second example of a vasculitis where we can say that the granuloma is going to be present. What we therefore need to understand is both the examples of large vessel vasculitis, whether we talk about temporal arthritis or whether we talk about Takayasu arthritis, are examples of granulomatous vasculitis. If we just try to understand the clinical picture of these kind of patients, patients are having the involvement of the common carotid and the subclavian vessels. So these patients are going to be having the development of neurological manifestations. Less blood is going to be going inside the brain. Patients are going to be having the development of a weak or a feeble pulse. And the patients at times, because of involvement of the internal carotid artery, are going to be having the presence of sudden onset of blindness. So just like temporal arthritis, this could again be an example of a condition in which the patients could be having a problem, sudden onset of blindness. And that is the significance of knowing about this kind of a disease, that we need to be doing some kind of an intervention at the earliest. In general, it is an example of a condition which is going to be associated with a relatively poor prognosis. One important fact that we must always understand with this kind of a disease with its relation to the involvement of the renal vessels. When we talk about these kind of patients, these patients at times are going to be having the involvement of the renal artery. Any inflammation in the renal artery is going to be associated with a decrease in the blood going to the kidney, and that is responsible for causing activation of the renin-angiotensin-aldosterone system. So involvement of the renal artery is going to be associated with renin-angiotensin-aldosterone system activation, and this is going to be responsible for causing development of high blood pressure or hypertension in these individuals. Why do we need to understand about that particular fact is, when we have a patient who is going to be having the development of hypertension because of a vascular problem of the renal artery, this is an example of a condition which is going to be given the name of renovascular hypertension. And why do we need to talk about this particular fact lies in a simple fact. When we talk about renovascular hypertension, this can be an example of a condition that can be seen in case of elderly individuals. It can be seen in case of young individuals. The reason for the development of renovascular hypertension in elderly individual happens to be the condition that is given the name of atherosclerosis. But when we talk about the most common reason for the development of renovascular hypertension, particularly in context of Indian patients, that happens to be non-specific aortoarthritis. Non-specific aortic inflammation. And one of the important reasons for the development of this kind of a non-specific aortic inflammation happens to be the condition that we are talking about as of now, which happens to be Takayasu arthritis. So the significance of knowing about Takayasu arthritis in the patients, especially in India, happens to be the fact that this condition is going to be associated with development of renovascular hypertension in the young patients. This is what we need to have an idea so far as the large vessel vasculitic disorders are concerned. We shift our attention to the second category of disorders, which are given the name of medium-sized vessel vasculitis. When we talk about the medium-sized vessel vasculitic disorders, they are example of disorders in which we are going to be having the involvement of the medium-sized vessels. The involvement of the medium-sized vessels would include, the examples can be involvement of the renal artery. We can be getting the involvement of something like the popliteal artery, or in some disease, as we are going to be talking about in few minutes down the line, we can even be having the involvement of the coronary artery. So these are example of medium-sized vessels, and any inflammation in them is going to be an example of a medium-sized vessel vasculitis. So the first example of a medium-sized vessel vasculitic disorder that we talk about is polyarteritis nodosa. If you look at the name of the disease itself, it gives us an important hint with respect to the fact that in this condition, multiple vessels are going to be affected. When we talk about polyarteritis nodosa, this is an example of a vasculitic disorder which is going to be seen involving young adults. As said earlier, in this particular condition, we are going to be having the involvement of multiple types of vessels. In few minutes down the line, we'll understand why exactly are we calling it as nodosa as well. Now, when we talk about this kind of a condition, it is going to be associated with the presence of the deposition of the immune complexes. Let us just recall the fact, any disease which is an example of an immune complex disease is an example of type 3 hypersensitivity reaction. When we talk about this kind of a disease, because of the fact it's an example of an immune complex disease, it is going to be having the presence of fibrinoid necrosis. What exactly is going to be responsible for the formation of immune complexes in these patients? That is having a microbiology correlation. This is an example of a condition in which we are going to be having the people, 30% of the patients having this kind of a disorder are having a history of hepatitis infection. So what we have is that there is going to be formation of surface antigen, and against this surface antigen we are going to be having the presence of the antibody. Both of them are going to come together, resulting in the formation of the immune complex. And these immune complexes are going to be having a deposition in multiple organs in the body. So for that very reason, we understand that polyarteritis nodosa is going to be an example of a multi-system vasculitic disorder. We need to remember the fact that because of this condition being an example of a medium-sized vessel vasculitis, characteristically and very importantly, what we find in these patients is that these patients are going to be having the presence of small vessel sparing. So as we shall see in a couple of minutes down the line, what exactly is the significance of knowing about this kind of a fact. Now let us talk about the involvement of different kind of organs in these patients. When we talk about the involvement of the organs in these patients, many organs can be affected. That is what we said. But what we need to remember over here is that in these patients, characteristically speaking, the lungs are not going to be involved. So the lungs are going to be spared in these patients, and that's a high stuff that they ask you on the boards. When we talk about the involvement of the organs, let us just talk about the involvement of the organs. Organ number one that we can talk about can be involvement of the kidney. Now when we talk about the involvement of the kidney, the patients are going to be having the involvement of the renal artery. And any involvement of the renal artery in these patients is usually going to be characterized by the presence of microaneurysm formation. Because of microaneurysm formation, less volume of blood goes to the kidney, and less volume of blood goes to the kidney. That is what is going to be responsible for causing activation of the RAS system. So again, that is what is going to be contributing to the development of hypertension in these patients. What we do need to remember as an important fact regarding this kind of a condition, that the patients are having kidney involvement going to be resulting in the formation of hypertension. But these patients characteristically are not going to be having the development of glomerulonephritis. That can be explained on the basis of a simple fact. When we are looking at the structure of a glomerulus, it is going to be containing afferent and efferent arteriole, and it contains tuft of capillaries. These are example of small vessels. So small vessels are not affected in a patient suffering from polyarteritis nodosa because of the fact it is an example of a medium-sized vessel vasculitis. So glomerulonephritis is not seen in these patients. An alternate way of asking about the same kind of a stuff. Histologically, glomerulonephritis is characterized by the presence of RBC casts in the urine. So when the patients are not going to be having glomerulonephritis, logically speaking, the patients are going to be having absence of RBC casts. That is what we need to be familiar with so far as the involvement of the first important organ is concerned. The second important organ which may be affected in these patients that we can talk about can be the involvement of the GI tract, and therefore the patients are going to be having the clinical manifestation of pain, or the patients could be having the presence of blood in the stools, what is being given the name of melena. Patients at times could be having the involvement of skin, and skin involvement in these patients is going to be characterized by the presence of nodules. The patients could be having the presence of papules, or they may even be having the development of ulcerations. Apart from that, patients could be also having the development of involvement of nerves in this kind of a condition. And neural tissue involvement in these patients is going to be characterized by an important lesion, what is given the name of mononeuritis multiplex. In fact, this kind of a lesion, the mononeuritis multiplex, particularly in the developed countries, is most commonly associated with polyarteritis nodosa. Though in the developing countries or the places where we still have the presence of leprosy, the mononeuritis multiplex is caused because of leprosy. So where we have a high prevalence of leprosy, it is caused because of leprosy. Where we have low prevalence of leprosy or total elimination of leprosy, the commonest cause of mononeuritis multiplex happens to be the condition like polyarteritis nodosa. What we can also have in these patients can be the involvement of something like the joints, or the patients could be even having the involvement of the central nervous system. So joint involvement is going to be seen in the form of development of arthralgia. Patients could be having pain. CNS involvement can be seen in these patients that can be associated with a high risk or development of seizures. So as we can understand, a multi-system inflammatory disorder, but please remember and revise that fact, lungs are spared, and in the kidney involvement, patients never ever get the development of glomerulonephritis. The next fact that we need to be familiar with regarding this kind of a condition is going to be the histological finding that we expect to see in these patients. When we talk about this kind of a condition, this kind of a disease is going to be having two phases. One can be an early phase and the second can be a late phase. The early phase of the disease is going to be characterized by the presence of fibrinoid necrosis. That is what is going to be present. And what we have in these kind of patients is the complete thickness of the vessel wall is going to be affected. So once you are having the complete thickness of the vessel wall that is going to be affected, this is given the name of transmural inflammation. On the other hand, in the advanced stage of the disease, in the late stage of the disease, as the inflammation is going to subside, this is going to be associated with the deposition of fibrous tissue. So patients are going to be having the presence of fibrosis in the vessel wall. Why that becomes important for us to understand is, let us just make a representation of a vessel wall. There are going to be the presence of active lesions or early lesions and the late lesions which are going to be coexisting. So let me say that this is an area where the patients are having active inflammation. So the patients are going to be having the presence of fibrinoid necrosis, and intermittently we are going to be having areas where we are having the deposition of the fibrous tissue. When we are going to be having a deposition of the fibrous tissue in the intermittent areas, these areas are going to be having a narrowing of the lumen. So what we find in these patients is, in the areas which are designated as these, we are having a normal lumen. In the other areas, like these areas, we are having a narrowing of the lumen. So normal lumen, narrow lumen, normal lumen, narrow lumen, that is what is going to be seen in these patients. And this is what is going to be responsible for giving a node-like appearance of the vessel. So that is what is responsible for the disease being given the name of the polyarteritis nodosa. So simply because of the nodular appearance of the vessel that we are going to be associating with the coexistence of the early and the late lesions in these patients. The next thing that we need to have an idea about this kind of a condition is the management of these patients. And because of the fact it is an example of a vasculitic disorder, so patients are going to be managed with the help of the anti-inflammatory drugs. Classically, that can be including something like steroids, or maybe in the advanced stages, patient may need to be given a stronger immunosuppressive drug, something like cyclophosphamide. That is how the management of this kind of a disease is being done. The second important example of a medium-sized vessel vasculitis is a condition that is given the name of Buerger's disease. When we talk about Buerger's disease, it is an example of a disease which is going to be characterized by the presence of necrotizing inflammation. And this kind of a necrotizing inflammation characteristically is going to be affecting importantly arteries. Subsequently, we are going to be having the involvement of veins, and then we can be having the involvement of nerves as well. What we therefore need to understand is that in these patients, the commonest anatomical structure which is going to be affected happens to be the artery, and the anatomical structure which is never going to be affected in these patients happens to be the lymphatic vessels. So arteries are affected, veins are affected, but the patients are never going to be having the involvement of the lymphatic vessels. Now when we talk about this kind of a disease, if we just make a representation with the help of a diagram, this is an example of a disease. Let us say this is a cross section of a vessel. It is going to be associated with the presence of occlusion of the vessel. So there is going to be the presence of a thrombus which is going to be causing occlusion of the vessel, and there is going to be the presence of only some areas in between which are going to be remaining patent. So for this very reason, the disease is also known by the second important name of thromboangiitis obliterans. Thromboangiitis obliterans. As the name itself is giving us sufficient amount of hint, what we have in this kind of a condition is that there is going to be an inflammation or angiitis resulting in the formation of a thrombus, which is going to be responsible for causing almost complete obliteration of the vessel lumen. Only some pockets are going to be seen which are going to be having the presence of a patency of the lumen. So only these areas that I am trying to make a representation with a red color marker are going to be having the presence of channels through which the blood can actually flow. Why do we need to talk about that fact is because this kind of a lesion characteristically and most commonly is going to be causing an involvement of the vessels in both upper as well as lower limbs. One of the commonest vessels that is affected in these patients happens to be the vessel of the lower limb, that is going to be the tibial artery. And because of the involvement of the tibial artery, the patients are going to be getting a reduced volume of blood in the lower limb muscles. So what exactly is going to be the importance? As and when this individual is going to be at rest, the person is not going to be having any symptoms. So person is going to be having no symptoms at the time when he is not walking. When this individual is going to start walking, the lower limb muscles are working more. When the lower limb muscles are working more, they would need more volume of blood for their function. But because of the thrombus and the obliteration or reduction in the lumen, less volume of blood is coming over here. So patients are going to be developing ischemic symptoms. So this is the time when the patients are going to become symptomatic. As and when the patient is going to stop walking, the patient is going to be having no symptoms again. Which means that patients are going to be having the development of symptoms only when they are exerting themselves, only when it is going to be the muscular activity taking place over here. So this is what is being given the name of intermittent claudication. So particularly as one of the initial manifestations of the disease, This is what is going to be seen in a patient suffering from Buerger's disease or thromboangiitis obliterans, presence of intermittent claudication. The other important thing that we must be familiar with is what exactly is the reason for development of this kind of a condition. This is an example of a condition that we typically see in case of young males. And majority of these young males are going to be having the presence of a history of smoking. So it is postulated that thromboangiitis obliterans may actually be an example of a hypersensitivity reaction to the presence of nicotine. And that is what is responsible for causing the development of vasculitis in these patients. Now, if we know that it is the smoking which is responsible for causing the trouble in the patient, that is helpful for the management of the patient as well. So the first thing that we would advise to this kind of a guy happens to be that he has to quit smoking. The second thing that can be done for the management of these patients can be administration of drugs which are going to be improving the blood supply in the lower limb muscles like vasodilators, or in extreme cases, the patients are advised to undergo surgery. If the patient is having a really advanced disease, so much so that even the surgical intervention which is intended to bring more amount of blood in the lower limb muscles is failing, then the patients may at times unfortunately have to undergo amputation. So what we need to remember over here is that in the interest of the patient, it is best that the patient be sensitized so as to quit smoking. Otherwise, the patient may be undergoing drastic consequences like surgery or even amputation. Talking about the next important example of a vasculitic disorder. The next important example of a vasculitic disorder that we need to be familiar with is a condition which is given the name of Kawasaki's disease. Kawasaki's disease actually is a pediatric disorder. So easy for us to remember, K for Kawasaki's and K for kids. It's an example of a condition that is going to be affecting a child who is going to be usually less than 4 years of age. What is going to be seen in this kind of a condition would be that the child is going to be having an inflammatory disorder of the blood vessel. So this child is going to be having one of the important hallmark clinical manifestations, that is fever. And along with that, the patients are going to be having what is given the name of, easy way to remember, the cream criteria. So patients are going to be having at times the presence of something like conjunctivitis. Patients are going to be having the development of rash. They are going to be having the development of edema. This is classically an example of edema which is going to be affecting the hands and feet. Patients are going to be having the development of adenopathy, which simply means enlargement of the lymph nodes. And the patients are going to be having the presence of mucosal ulcers or mucosal lesions. So when we want to make a diagnosis of Kawasaki's disease, what we must always show in the patient happens to be fever has to be a consistent finding. And out of the 5 criteria, the cream criteria written over here, at least 4 need to be present in the patient. So presence of fever plus 4 out of 5 criteria that I made a mention of should be present. Now when we talk about each of these criteria, some of them are going to be having their special features that we should be having an idea about. When we talk about the conjunctivitis in these patients, that is an example of a non-exudative conjunctivitis. When we talk about the presence of rash, characteristically the rash in these patients is going to be seen causing an involvement of the extensor surface of the body. When we talk about the presence of edema, the edema in these patients is going to be associated with hands and feet. And when we talk about the presence of adenopathy, this is going to be associated with involvement of the cervical group of lymph nodes. When we talk about the involvement of the mucosal lesions, patients can be having the development of mucosal ulcers. Patients at time are also going to be having the appearance of their tongue, which is being described as strawberry tongue. So the presence of edema of hands and feet, presence of a non-exudative conjunctivitis, presence of a rash, presence of a cervical lymphadenopathy and a strawberry tongue along with fever should strongly alert you for the fact the patient is going to be having Kawasaki's disease. Now, why exactly should we be interested in knowing about Kawasaki's disease lies in the fact that this is an example of a condition which is going to be having two additional important findings. Finding number 1, these patients are going to be having an elevated platelet count. So patients are going to be having the presence of thrombocytosis. Fact number 2 that we need to have an idea, these patients quite frequently are going to be having inflammation of the coronary vessels. So patients are going to be having the presence of coronary vasculitis. Now why that becomes important? Whenever there is an inflammatory condition affecting the vessel, it can be responsible for causing the development of a clot. And if a patient is going to be having thrombocytosis, that may even cause exacerbation of the size of the clot. So this is responsible for causing a decrease in the blood supply to the heart. And that may actually be responsible for causing the development of myocardial infarction. So why we need to talk about Kawasaki's disease lies in an important fact that this is the most common cause of myocardial infarction in case of a child. And this can be attributed because of the presence of the coronary vessel inflammation. It may be exacerbated also because of the fact the patients are going to be having thrombocytosis. So as and when we want to talk about this kind of a disease, that's a practical significance. Now when we want to make a diagnosis of this condition, it's an inflammatory condition, so patients are going to be having elevated value of TLC. Patients are going to be having an elevated value of ESR. But important from the perspective of board exam question, we must be familiar with the fact patients have elevated platelet count. How exactly do we expect to manage these kind of patients? The management of these patients is done with the help of a strategy which is going to reduce the coronary artery inflammation. And the best way of decreasing the coronary artery inflammation in these patients happens to be administration of intravenous immunoglobulins. Because we are familiar that higher platelet count is present in these patients, so we have to give an antiplatelet drug as well in these patients, and that happens to be aspirin. Two facts that we must always pay attention to over here. When we are talking about aspirin, aspirin usually is going to be avoided in case of a febrile child. For the simple fact, aspirin is going to be responsible for causing mitochondrial damage, and that is responsible for causing a higher risk of development of Ray's syndrome. But this is an example of a febrile child who is going to be given aspirin so as to reduce the chances of development of coronary artery inflammation. Second fact, for most of the inflammatory conditions, we usually talk about administration of drugs like steroids. But this is an example of a condition in which steroids are going to be avoided in the patients. If we happen to give steroids in these patients in preference to intravenous immunoglobulins, studies have shown that the patients are going to be having a higher chance of development of coronary artery aneurysm. So the first line therapy that we have in these patients happens to be intravenous immunoglobulins along with aspirin. Steroids are to be avoided in these patients. That is what we need to have an idea so far as Kawasaki's disease is concerned. Talking about the next important example of a inflammatory disorder, the third category of inflammatory disorders that we talk about happen to be the small vessel vasculitis. So in our discussion of the medium vessel vasculitis, we did talk about polyarteritis nodosa, we talked about Buerger's disease, and we talked about the Kawasaki's disease. In this condition, we are going to be having a discussion about the small vessel vasculitis. Now, when we talk about small vessel vasculitis, this is going to be associated with involvement of the small vessels, which by definition means involvement of arterioles, capillaries, and venules. One of the important findings that we have in this kind of a condition is presence of an autoantibody which is given the name of ANCA. To have a better understanding about ANCA, let us just make a rough description of a neutrophil. So this happens to be a neutrophil, and the neutrophil is going to be having the presence of two important types of antigens. Antigen number 1 can be an antigen which is present in this area, that means in the perinuclear area. So when you have formation of antibody against this kind of an antigen, this antigen is what is being given the name of myeloperoxidase, and therefore the antibody that is going to be seen in this condition is given the name of P-ANCA. P for perinuclear, that is the location of the antigen. A second antigen that we have in the neutrophil is a cytoplasmic antigen, And this kind of an antigen is what is being given the name of proteinase 3. So when we have an antibody which is going to be produced against this kind of an antigen, it is going to be cytoplasmic antibody. And this kind of an antibody therefore is given the name of C anchor. So P for perinuclear, C for cytoplasmic, the location of the antibodies. Now when we talk about this kind of an antibody, we need to have an idea about the conditions where we expect to find each of them. But let us just have an update, and that is in terms of the fact that the earlier name of the antibody was P anchor. It is now being referred by the name of MPO anchor. So particularly in fresh set of questions, you may encounter that the patients are having a vasculitis and they are having the presence of MPO anchor. Similarly, the new name for C anchor happens to be, this is now called by the name of PR3 anchor. Now let us just talk about the example of conditions where we expect to find each of these antibodies one by one. When we are talking about a patient who is going to be suffering or having the presence of P anchor or MPO anchor as we call it now, this is going to be a group of patients which are going to be suffering from a condition known by the name of microscopic polyangiitis. A second example of a disorder where we have the presence of MPO anchor is going to be a condition which is given the name of Churg-Strauss syndrome. And a third example of a condition that we need to have an idea about over here happens to be a condition which is given the name of Goodpasture syndrome. On the other hand, when we are talking about something called as PR3 anchor, PR3 anchor is seen as a manifestation or a finding in case of a patient who is going to be suffering from a condition which is given the name of Wegener's granulomatosis. Now when we are talking about this kind of fact, let us also be clear with another important association. We are going to be talking about the presence of this kind of an antibody P anchor in our subsequent discussion in the GI tract as well. We just need to be familiar with the fact that P anchor is an example of an antibody that can also be seen in a patient who is suffering from a condition which is called by the name of ulcerative colitis. However, we must be familiar with a simple concept that the P anchor that you see in a patient having ulcerative colitis is qualitatively different from the P anchor that you see in a patient having vasculitis. In a patient who is going to be having ulcerative colitis, the P anchor antibody is actually produced against a nuclear envelope protein or nuclear envelope antigen. But over here in vasculitis, the P anchor is produced against the myeloperoxidase. So though the terminology is going to be the same, but for the sake of a concept which is extremely important, P anchor in ulcerative colitis is different from the P anchor that we see in case of vasculitis. With that kind of a background, we now have a discussion about the disorders. So when we talk about the disorders, the first important example of a disorder that we talk about is a condition which is given the name of Wegener's granulomatosis. Wegener's granulomatosis, nowadays also being referred by the second important name of granulomatosis, with polyangiitis. We need to be familiar with the fact that this is an example of a condition which is going to be characterized by the presence of necrotizing granulomas in most of the places in the body where the disease is going to be present. Let us just have an idea about the kind of the organs in the body which are going to be affected by this kind of a vasculitis. When we talk about the involvement of the organs in case of Wegener's granulomatosis, the rule of involvement of the organ happens to be something like this. So if you remember the fact, it is always going to be helpful for you to remember organs affected in case of vaginous granulomatosis. So rule of involvement of organs are for involvement of the kidneys. Patients are going to be having an involvement of the upper respiratory tract, which means we are talking about the involvement of the ear, involvement of the nose and involvement of the throat in the patients. And patients are going to be having the involvement of the lungs as well. Before we proceed further, let us just have an important discussion, and that is that when we are talking about the involvement of each of these organs, it is the upper respiratory tract that is the most commonly affected site in case of a patient having granulomatosis with polyangiitis. Second fact, when we talk about the disease, necrotizing granulomas are seen in case of upper respiratory tract. Necrotizing granulomas are also seen in case of the lungs. But we do not have necrotizing granulomas in case of the kidneys. So let us now have a detailed discussion about each of the organs with respect to this basic background of information. In context of involvement of the kidneys, what we have in these patients is, patients are going to be having the development of a lesion which is given the name of crescentic glomerulonephritis. Crescentic glomerulonephritis, as we are going to be having a discussion in a separate section in the renal disorders, is an example of a condition which is going to be responsible for causing rapid deterioration in the renal function. So this is an example of a condition in which the patients are going to be having a glomerulonephritis, and for that very fact we must be familiar that these patients are going to be having the presence of RBC casts in their urine. When we talk about the involvement of the upper respiratory tract, that is in the form of involvement of the ear, so patients are going to develop middle ear infection, otitis media. Patients can be having involvement of the nose, that can be seen in the form of septal perforation. Patients are even going to be having a damage to the bridge of their nose, which can be responsible for an appearance given the name of saddle nose. And in the involvement of the throat, patients are going to be having the presence of strawberry gums. Patients are going to be having the development of subglottic stenosis. So this is something which is characterized by the presence of inflammation below the vocal cords. And that is something which is characteristically seen so far as these patients is concerned. We must be familiar with the fact that when we are talking about strawberry gums, that is what is seen as a finding of a patient having vaginous disease. And when we are talking about something which is given the name of strawberry tongue, that is what we discussed a few minutes back. That is a finding of a patient suffering from Kawasaki's disease. In the involvement of the lungs, what we find in these patients is that these patients are going to be having the development of cough. Patients are going to be having the presence of blood in the sputum. So patients are going to be having hemoptysis. If at all we happen to see the chest X-ray of these patients, an important finding that we must be familiar with over here is that these patients are going to be having the presence of cavitary lesions in their lungs. So presence of cough, hemoptysis, cavitary lesions, along with the involvement of the kidneys, along with the presence of subglottic stenosis, otitis media or nasal involvement, that is highly suggestive of the presence of vaginous granulomatosis or granulomatosis with polyangiitis. As and when we wish to make a diagnosis of this kind of a condition, the diagnosis of this kind of a condition is done on the basis of the presence or demonstration of the antibody, and this antibody, as we talked about earlier, happens to be the C ANCA. So C ANCA, which is as of now being given the name of PR3 ANCA, that is the antibody which is going to be seen maximally in the patients, and that is what is going to be helpful in the diagnosis. Diagnosis in these patients is going to be confirmed on the presence of biopsy, and in the renal biopsy the patients are going to be showing us the presence of crescentic glomerulonephritis. As and when we talk about having a management of this kind of a disease, the management of this kind of a disease can be done with the help of anti-inflammatory drugs or immunosuppressive drugs, and the drug of choice that is going to be given to these patients is going to be cyclophosphamide. So this happens to be the drug of choice for the management of this condition. The patients may actually be given steroids as well, but usually the response of cyclophosphamide happens to be the best, and therefore that becomes the drug of choice. So far as these patients are concerned, the reason for the presence of mortality in these patients is usually because of the kidney involvement. So when the patients are going to be having crescentic glomerulonephritis, the patients are going to be having a very high chance of development of renal failure. And it is this renal failure which is actually going to be contributing to the mortality of the patients. So this is what we need to have an idea so far as the disease Wegener's granulomatosis is concerned. Having a discussion now about the second important example of a small vessel vasculitis, we need to be familiar with a disease that is given the name of microscopic polyangiitis. The disease itself is giving us a very important hint so far as its properties are concerned. It's an example of a microscopic vasculitis. So what we have in these patients is that this is an example of a condition which is going to be characterized by involvement of small vessels. Polyangiitis, multiple vessels are going to be affected in these patients. Now the name polyangiitis at times is going to be creating a confusion in some people's mind because of its similarity with something called as polyarthritis nodosa. So polyangiitis, polyarthritis may be at times confused. Therefore, we just remember that confusion because in a patient having polyarthritis nodosa, we do not get involvement of the small vessels. Let us just remind ourselves that in a patient suffering from polyarthritis nodosa, we are going to be having a non-involvement of the lungs. Whereas when we talk about a patient suffering from microscopic polyangiitis, lungs are affected in these patients. In patients suffering from microscopic polyangiitis, kidneys are affected, and because it is a small vessel disorder, so patients are going to be having the presence of glomerulonephritis as well. On the other hand, when we are talking about a condition like polyarthritis nodosa, patients are having kidney involvement, but the patients are not going to be having glomerulonephritis. The other way of making a diagnosis of this kind of fact lies in a situation that when we are talking about a patient suffering from microscopic polyangiitis, these patients are having the presence of an antibody that we discussed, P-ANCA. Whereas such an antibody is going to be absent in case of a patient having polyarthritis nodosa. So both of them are examples of multisystem inflammatory disorders, but there is a difference with respect to these important four properties of the disorders. So microscopic polyangiitis, small vessels are affected, patients are going to be having involvement of lungs as well as presence of glomerulonephritis, and the patients are having the presence of P-ANCA positivity. The other important fact that we must be able to differentiate at the time of a question in the board exam, we should be able to distinguish between this condition, microscopic polyangiitis, from a condition like what we discussed about as the first example of a small vessel vasculitis, which is Wegener's disease. So the first important difference that we can understand is the nature of the antibody that you see in a patient having Wegener's disease happens to be C-ANCA, or more appropriately I would call it as PR3-ANCA. In case of a patient having microscopic polyangiitis, the patients are going to be having the presence of P-ANCA positivity. Fact number 2 that we need to remember is that as we discussed earlier, patients having Wegener's granulomatosis are going to be having involvement of the kidneys. Patients have the involvement of the lungs, and the patients are also going to be involvement of the upper respiratory tract. In contrast, when we are talking about a patient who is going to be suffering from microscopic polyangiitis, there is no nasopharyngeal involvement in these patients. So these patients are not going to be having the manifestations like the septal perforation. They are not going to be having the bridging nose presence. They are not going to be having the presence of something like pharyngitis or even the presence of subglottic stenosis. So these are the important facts by which we are going to be having a distinguishing between microscopic polyangiitis and disorders like vaginous, and the earlier discussion that we talked about, differentiation between microscopic polyangiitis and polyarthritis nodosa. Talking about the next important fact, what exactly are going to be seen as expected findings in a patient suffering from this kind of a disease? In a patient suffering from microscopic polyangiitis, the patients are going to be having the presence of same stage of inflammation in the affected vessels. So that is again a very high stuff that we need to remember from the perspective of the exam. Different stages of inflammatory situations are present in a patient having polyarthritis nodosa. So if you can possibly recall, there was an early stage because of the presence of necrosis, and there was a late stage characterized by fibrosis resulting in narrowing of the lumen. In this condition, same stage of inflammation is present. Second important fact, this is an example of a condition in which we are not going to be having the presence of a granuloma. So granuloma formation is not seen in this kind of a condition. Granuloma formation is a feature that we see in a patient having vaginous granulomatosis. The other important thing that we need to be familiar with regarding this kind of a disease is the association with certain etiological factor. So it can be seen with certain types of infections, maybe streptococcal infection, can be seen with administration of antibiotics like penicillin, and it may be seen as a component of autoimmune disorders like SLE. So these are the etiological factors that we associate with the development of microscopic polyangiitis. For the fact it is an example of an inflammatory condition, the management of these patients is going to be done with the help of administration of steroids. So steroids are going to be helpful so far as the management of these kind of patients is concerned. Talking now about the third important example of a small vessel vasculitic disorder. This is a condition which is given the name of Henoch-Schönlein purpura. Henoch-Schönlein purpura. Now when we talk about Henoch-Schönlein purpura, it is an example of a condition which is going to be classically or most commonly going to be affecting children. So Henoch-Schönlein purpura is an example of a disorder that you see in case of high number in case of children. So pediatric disorder, and that is the significance, it's the commonest vasculitis that you have in case of children. The commonest vasculitis, as we can recall, which we found in case of adults, happen to be temporal arteritis, but this disease happens to be the commonest vasculitis in case of children. Let us talk about the pathogenesis of this condition. So the child is initially going to be having a history of upper respiratory tract infection. Because you are having the involvement of the respiratory mucosa, so this is going to be characterized by an overproduction of IgA antibody, and this IgA antibody is now going to be responsible for the formation of immune complexes. Now again, because of the fact that you are having the formation of immune complexes in this condition, this is going to be an example of what kind of hypersensitivity reaction? Type 3. What we find in these patients is that these immune complexes are going to be having their deposition in different organs in the body. So patients are going to be having the involvement of the organs like the kidneys. That is one of the preferred sites for the deposition of the immune complexes. Patients are going to be having the involvement of the skin. They can be having the involvement of the GI tract, and they are going to be having the involvement of the joints. Because of involvement of each of these organs, what we see as clinical manifestations in the patients are going to be, the patients are going to be having the development of glomerulonephritis. So one of the findings of this kind of a glomerulonephritis is patients are going to be having the presence of microscopic hematuria. When we talk about the involvement of the skin in these patients, involvement of the skin in these patients is going to be characterized by the formation of purpura. But a very important fact that we must remember over here is that this kind of a purpura is responsible for the formation of a skin rash. And this kind of a skin rash classically is going to be having an extensor surface distribution. So patients are going to be having this kind of a rash which is going to be affecting their lower limbs. Patients are going to be having the involvement of the buttocks. So presence of a skin rash on the extensor surface going to be causing an involvement of the lower limbs and the buttocks is what is going to be seen as a manifestation of Henoch-Schönlein purpura. Why do you need to talk about this particular fact is also because of the important associations. Normally when we are talking about the term purpura, this is a term that we associate with the bleeding taking place in the skin associated with reduced platelet count. However, the reason for the rash in these patients is not going to be a decrease in the platelet count. The reason for the development of rash in these patients happens to be the development of vasculitis. So what we need to understand is that the platelet count in these patients is going to be normal. And because the platelet count in these patients is going to be normal, this disease is going to be given the name of non-thrombocytopenic purpura. Non-thrombocytopenic purpura. In spite of a normal platelet count, patients are having the bleeding manifestations in the skin like purpura. The other name for the same disease, it is also known by the name of anaphylactoid purpura. So non-thrombocytopenic purpura and anaphylactoid purpura are the terms that we associate with the development of skin rash in a patient suffering from Henoch-Schönlein purpura. Talking about the involvement of the organs like the GI tract, patients are going to be having the involvement of the GI tract which can be seen in the form of development of maybe abdominal pain, and patients could even be having the development of bleeding or melena. In the joint involvement, patients are having deposition of the immune complexes over here. So patients are going to be having the development of arthralgia. So what we find in these patients is classically there is going to be a spectrum of the organs which are going to be affected, starting with the involvement of the renal tissue, skin, GI tract and joints. Let us not forget what exactly was the reason for the development of this kind of condition, that is IgA antibody. And the clinical significance, it happens to be the most common vasculitis that we have in case of children. Please be familiar with and revise a fact with respect to the two other names for the same condition, non-thrombocytopenic purpura as well as anaphylactoid purpura. So this kind of a classical picture is what is going to be helpful for cracking a question in the exam. Child having a history of upper respiratory tract infection, having a development of a skin rash which is having an extensor distribution, having the presence of maybe altered color of urine, presence of pain in the joints and the abdomen, maybe with the presence of blood in the stools or melena. This is what we need to be familiar with so far as this kind of a condition is concerned, the Henoch-Schönlein purpura. Talking about the next important example of a disorder, the next important example of a disorder about which we are going to be having a discussion is a condition that is given the name of Churg-Strauss syndrome. Churg-Strauss syndrome. Churg-Strauss syndrome is an example of a small vessel vasculitis. It is again going to be an example of a condition in which we are going to be having a necrotizing vasculitis. And this kind of a necrotizing vasculitis is going to be having two important associations. It is going to be again characterized by the presence of granuloma formation. So if we can recall, this is the fourth example of a disorder that we are talking about where we have granuloma formation. We had two important disorders where we talked about granuloma formation, both examples of large vessel vasculitis, and we have two examples of disorders which are small vessel vasculitis where we get granuloma formation. One was vaginous granulomatosis and the second one is Churg-Strauss syndrome. The second association that we have with this kind of a condition is, this is an example of a condition which is associated with the presence of eosinophilia. So small vessel inflammatory condition with granuloma formation with eosinophilia, that is seen as a finding of Churg-Strauss syndrome. When we talk about this kind of a disorder, what we need to remember over here is the example of a clinical condition or a situation where the patients are going to be having Churg-Strauss syndrome. So easy for us to remember. If you can recall the example of that hypersensitivity reaction where we expect to find eosinophilia, type 1 hypersensitivity, and the classical prototype example of type 1 hypersensitivity reaction, the clinical disorder happened to be bronchial asthma. We find that these patients could also be having this kind of an issue because of intake of certain types of drugs. And the most important drug that we have in this category which can be responsible for causing unmasking of Churg-Strauss syndrome again is an example of an anti-asthmatic drug, that is something like a drug known by the name of Montelukast. So this being an example of a leukotriene receptor antagonist, it may be responsible for causing unmasking of Churg-Strauss syndrome. What we have regarding this kind of a condition as a findings is going to be that these patients are going to be having involvement of small vessel vasculitis, which is going to be affecting multiple organs in the body, and that is going to be causing undoubtedly the involvement of the lungs. Patients are going to be having at times dermatological involvement, and maybe the patients are going to be having even cardiac tissue involvement. So involvement of the lungs is what is going to be seen in these patients, skin involvement and cardiac tissue involvement. Some patients having this kind of a disorder may be having the presence of a antibody in them, that is going to be P-ANCA. So this is what we need to be familiar with so far as Churg-Strauss syndrome is concerned. So key points that we must keep in mind: necrotizing granuloma, eosinophilia presence, association with asthma, and we need to be familiar with the fact, again an example of a disorder where some of the patients could be having the presence of P-ANCA antibody. We now talk about an example of a condition which is given the name of Behçet's disease. Behçet's disease is an example of a condition which is going to be causing an involvement of the small vessels. So this is an example of a small vessel vasculitis. Now in the pathogenesis of this condition, we are going to be having a very important role that is being played by helper T cell subtype 17. This helper T cell subtype 17 is actually going to be responsible for causing neutrophilic infiltration in the vessel wall. What we need to be familiar with is that this is an example of a condition which is going to be having a higher chance because of the genetic predisposition. Particularly, it is associated with HLA-B5 as well as HLA-B51. So higher chance of development of this kind of a condition. What is also important for us to understand is that in these patients, we are going to be having the presence of anti-endothelial cell antibodies. May I just take that opportunity to revise with you what was the other example of a condition where we were having anti-endothelial cell antibody? Yes, anti-endothelial cell antibodies were also present in case of a medium-sized vessel vasculitis, which was given the name of Kawasaki's disease. Now, if you are looking at an advanced question, especially if you're targeting an AIIMS or a JIPMER-like exam, what they'd asked you earlier is, what is the antigen against which this antibody is produced? The name itself is what will help you remember this always. Remember, A for anti, A for alpha, E for enolase. So alpha enolase, that is present in the cells of the endothelium, that means endothelial cells. Alpha enolase in the cells of the endothelium is the main antigen against which these antibodies are produced. What we are going to be having as a clinical manifestation of these patients is the patients are going to be having a classical triad. So when we read about the same condition, clinically we understand the fact that these are the patients who are going to be having the development of oral ulcers, which is going to be the hallmark or the pathogenic finding clinically. Patients also are going to be having the presence of genital ulcers. And what we also find is that a lot of these patients are going to be having ocular involvement in the form of development of uveitis. So as and when you read a question in the exam which is talking about Behçet's disease, this is going to be given the other important name of, as you can understand, oculo, because eye is involved, oro, genital syndrome. This is quite similar to something that we talked about in case of Kawasaki's. So in Kawasaki's, you were having involvement of mucosa, you were having involvement of skin, you were having the involvement of the lymph nodes. So that is given the name of mucocutaneous lymph node syndrome. This condition is given the name of oculo-oro-genital syndrome. We need to understand the fact that because of the presence of the anti-endothelial cell antibody. That is one thing which is helpful in diagnosis. The second thing is biopsy showing you presence of the neutrophilic infiltration in the small vessels along with the clinical presentation of the oculourogenital syndrome. And what can be done in these patients is an example of a test that they had asked you in the exams earlier. This is given the name of Petherge's test. So an example of a needle prick based test in which you are going to be looking at the development of a papule after a duration of 24 to 48 hours. Just remember the name, that is more than sufficient. Petherge's test is useful for making a tentative diagnosis or helpful in diagnosis of which vasculitis? Behçet's disease. This being an example of a vasculitic condition, easy for us to understand, treatment of the patients is going to be done with the help of immunosuppressive therapy, which can be with the help of drugs like steroids or other immunosuppressive agents. That is what we need to be familiar with so far as Behçet's disease is concerned. Starting off with the discussion, the first example of a vasculitis that I placed in front of you happens to be temporal arteritis. Let us just recall the fact, the significance knowing about temporal arteritis. It is the most common vasculitis disorder that we have in case of adults. Recall that when we are talking about the commonest vasculitis disorder that we have in case of children, that happens to be Henoch-Schönlein purpura, but the commonest one that we have in case of adults happens to be temporal arteritis. Now from the name itself, you get a very important hint. It is an example of an inflammatory condition which is going to be associated with inflammation of the superficial temporal artery, and therefore, as you can recall from our video section discussion, the commonest symptom that we have in patients happens to be headache. The most specific symptoms, however, that we have in these patients happens to be jaw claudication. Now, if you suspect that your patient is going to be having temporal arteritis, this being an example of a condition which can result in a threatening complication, or it can result in a complication which is going to be sudden onset of blindness, it is important for you to make a diagnosis of this condition at the earliest. These patients, apart from headache, apart from jaw claudication, can also be having polymyalgia rheumatica. When we are suspecting this condition and to confirm a diagnosis, you would like to do a temporal artery biopsy. Recall the fact that the minimum piece of the biopsy tissue that you require for the diagnosis of this condition is 1 centimeter, and in a lot of patients, multiple biopsies are going to be required for making a diagnosis of this condition. Now, when you look at the histological findings, this is a condition in which the patient is going to be having severe narrowing of the lumen. At the same time, it is an example of a granulomatous vasculitis. So what you have in these patients at times is the presence, or characteristically the presence of something like the giant cells. So severe narrowing of the lumen as well as the presence of giant cells is what is going to be a diagnostic feature so far as temporal arteritis is concerned. Why exactly do we need to be familiar with this kind of a condition is because you don't want your patient to have sudden onset of blindness. Therefore, what you just need to remember and revise over here is that if you suspect this condition to be present in your patient, you have to administer intravenous steroids at the earliest. So that's an important point with respect to this kind of a disease. An extra edge piece of information that we can be just familiar with regarding this kind of a condition is that when we are using a special stain, what is going to be given the name of Van Gieson stain. This is an example of a stain which is going to be useful for making a detection of the elastic lamina. So what we find in these kind of patients is that there is going to be characteristically, and that is what I am marking over here, the fragmentation of the internal elastic lamina. So the biopsy finding of these patients can be the presence of a granulomatous inflammation, as well as what we find in these patients is that there is going to be a characteristic fragmentation of the internal elastic lamina. That is what is going to be helping you to crack an advanced question in the exam with respect to temporal arteritis. The next important example of a vasculitic disorder about which we need to have an idea happens to be Takayasu arteritis. Let us just revise the fact that Takayasu arteritis, just like temporal arteritis, is also an example of a large vessel vasculitic disorder, and this particular disorder is also an example of a granulomatous vasculitis. Now, the difference therefore that we need to be familiar with regarding this condition and the condition temporal arteritis is that Takayasu arteritis is an example of a condition that is going to be seen in case of young patients. So, if you get a picture in the exam suggestive of granulomatous vasculitis and saying that there is a characteristically a large vessel involvement and that happens to be an elderly patient, think in terms of something like temporal arteritis. And if that happens to be a large vessel granulomatous vasculitis affecting a young patient less than 50 years of age, think in terms of Takayasu arteritis. Recall the fact that in a patient suffering from Takayasu arteritis, we characteristically are going to be getting the involvement of the aortic arch. So that's an example of a condition that is also being given the alternative name of aortic arch syndrome. For that very reason, what we find is that the aortic arch and the major branches of the vessels that are going to be arising from this area are going to be demonstrating to you severe constriction, and that is what is going to be at times responsible for the clinical manifestations of the disease. Clinically, because in these patients you are characteristically going to be having the involvement of the subclavian vessels, so when you try to palpate the pulse of these patients, at times it is possible that because of the less blood coming
You may not be able to palpate the pulse of the patient. So a third name that is given to the same condition happens to be pulseless disease. Why exactly do we need to be familiar with this kind of a condition at a clinical level is because of the fact that this is again an example of a condition in which the patients can be having sudden onset of blindness. So both large vessel vasculitic disorders are granulomatous in nature. Both of them can be having a clinical presentation in the form of sudden onset of blindness in the patients. The next important example of a vasculitic disorders about which we need to have an idea happens to be polyarteritis nodosa. As you have discussed in the theory section, that when we are talking about polyarteritis nodosa, it's an example of a immune complex disease. That means it's an example of a type 3 hypersensitivity reaction. Recall the fact that it is an example of a condition which is going to be associated with infection caused by hepatitis B. So the hepatitis B surface antigen and the antibody produced against it are going to result in formation of an immune complex, and these immune complexes are going to be responsible for causing vasculitis. When you are looking at the histological picture in these patients, the first fact that I want you to appreciate in these patients is this color pink to red deposition. So that is what is going to be characteristically associated with something like fibrinoid necrosis. Fact number 2 that you should be able to recall with these patients is this is an example of a vasculitic disorder affecting young patients, which is going to be associated with the presence of a transmural inflammation. So you have a combination of fibrinoid necrosis as well as transmural inflammation, which is going to be a characteristic histological finding so far as polyarteritis nodosa is concerned. From the name itself, let us just recall quickly, as we have discussed in the video section, that in these patients you can be getting the involvement of multiple types of organs. But characteristically what we need to remember is that these patients are not going to be getting involvement of the lungs. Secondly, even though these patients are going to be getting the involvement of the kidneys, but in these patients we are not going to be having the development of glomerulonephritis. So that's an exceptionally high point that we should be able to recall in the exam as well. Now this is an example of a condition that we should be able to be recall that it is going to be corrected or it is going to be managed with the help of administration of steroids. The next important example of a vascular disorder that we need to understand is something like Kawasaki's disease, and as we can recall from the video section, K for Kawasaki, K for kids, so it's a pediatric vasculitic disorder. The patients are going to be diagnosed with the help of the fever plus cream criteria. We are going to be having the presence of conjunctivitis, we are going to be having the mucosal involvement, there is a unilateral cervical lymphadenopathy in these patients, and the patients can be having mucosal lesions as well, along with the presence of a skin rash. Why that disorder is important for you to be able to pick up as a physician, these patients are going to be having point number 1, increased platelet count. Fact number 2, the patients are going to be having the presence of coronary artery involvement, which is going to be responsible for causing severe narrowing of the coronary artery. Now this combination of thrombocytosis as well as the presence of coronary artery vasculitis is what is going to be responsible for a dangerous complication in the patient, and that is myocardial infarction. So Kawasaki's happens to be the commonest cause of myocardial infarction so far as children are concerned. Because of the fact that myocardial infarction can be a life-threatening complication in these patients, so management of these patients is done with the help of administration of, please recall, intravenous immunoglobulins and aspirin. That is what we need to be familiar with so far as Kawasaki's disease is concerned.